Right, hi everyone. Welcome to today's session on renal medicine. First of all, I'd like to extend a huge congratulations on finishing medical school and securing your foundation posts. Transitioning into life as a doctor can feel equally part exciting, but also quite intimidating. And that is 100% normal. I think renal rotations themselves can be quite daunting. I think they can have a reputation for being quite complex and very academic, but day to day on the wards, you're not really expected to be some, nephrologist. But what is expected of you is being able to spot sick patients, doing a safe assessment, avoiding any prescribing errors, and being able to escalate appropriately. So today, Dr. Vinay Saini will be giving you guys a pragmatic guide to those 4 things built around real world bleeps and common mistakes. So it's now my pleasure to introduce you to our speaker, Dr. Vinay Saini. So Vinay has spent this current year, his FY3 as a Clinical Teaching Fellow in the West Midlands, and he's about to start his ACCS Anaesthetics training in August. During his foundation training, he's completed rotations in gastro, renal, ITU, as well as Jerry's. So he knows exactly what he's talking about and kind of how to kind of navigate a busy medical ward and navigating those first on-call shifts. So in today's session, he'll be sharing the practical tips and principles that he wishes he'd known when he first started. So before we move on, I just wanted to make you guys aware and talk a little bit about Medics&Me and what we do. So we have a growing library of foundation prep series that you might find useful. So we already have some now on our YouTube channel. That includes one on max facts, general surgery, urology, and neurosurgery, as well as respiratory, which we did yesterday. We also have plenty more sessions that are coming up. So we've got gastroenterology tomorrow, Jerry's on Friday, and cardiology early next week. And don't worry if you can't attend, as these will be put onto our YouTube channel. Alongside these sessions, Medics&Me also offers careers blogs, teaching opportunities, quality improvement, and research projects, as well as mentoring opportunities. So I'd encourage you all to have a look at the website and follow us on social media to keep up to date with everything that's coming up. So without further ado, I'll just hand over to Vinay to start the session.
Thank you for the introduction, Zara. And thank you for those that have attended. So here we have a roadmap for today's session. Essentially, the session is designed to give you guys the practical knowledge that we'll actually use on the wards. We're going to cover how to approach common renal problems, how to manage AKI, prescribe fluids safely, understand when dialysis is needed, and finish with some practical advice on prioritization and surviving your first few weeks in the job. So one of the biggest misconceptions about working in renal is that you need to become a mini nephrologist overnight. But in reality, your role is exactly the same as any other medical job, and that is to keep patients safe. And this comes down to 3 main things. First is being prepared, knowing your patients and checking results. You should also be preparing for rounds as well and anticipating problems before they become emergencies. Second is being visible. You should be able to answer bleeps promptly, communicate with nurses, pharmacists, and seniors, update family members, and avoid letting things fall through the cracks. And above all, it's most important to be safe. When someone deteriorates, you need to go back to your A2E assessment, prescribe carefully, document clearly, and never be afraid to escalate if you're worried. Nobody will ever criticise you for asking for help. The consultants and the registrars are the ones that are there to make the complex nephrology decisions. Your job is to recognise when something isn't right, start sensible first-line management, and involve the right people at the right time. If you can do these things consistently, you'll be an excellent foundation doctor. So here is an example rota. Yours may look different depending upon the trust that you guys start your first job in, but generally you can see that shifts are split into 2 main groups. On a normal working day, which we can see in red, your role is all about patient continuity of care. You'll prepare for the ward round, you'll review the investigation results, you'll update patients and their families, you'll chase investigations, you'll complete jobs, and help move the patient safely through their admission. Whereas on your on-call shifts, that's long days and nights, you will cross-cover several wards, you will clerk new admissions, attend arrests, and respond to bleeps. And so your focus shifts from continuity of care towards prioritization, assessing acutely unwell patients, and safe decision-making. But regardless of the shift, your mindset stays exactly the same. You first assess safely, you start initial management, and then you escalate when you're worried. So, talking a little bit more about those normal working days, a huge chunk of your morning is going to be spent on rounds. And good preparation for your ward round means that they run 10 times smoother. Beyond the standard history and vitals, a renal review comes down to 4 core things. First, you want to look at the blood trends and the fluid status of the patient. Then you want to assess if the patient is on dialysis. If they are, you need to know their schedule, their target dry weight, and what access type they have. Then you need to chase investigations like recent imaging, pending biopsies, and microbiology, and any autoantibody screens that have been sent off. And then finally, you need to review the medications. You need to consider holding nephrotoxic agents and adjust the dosing of drugs in response to a patient's kidney function. Once you've gathered all that information, your next job is getting it down into the notes. So on the screen here, I've included a mock example of a ward round note. The key takeaway for you guys here is that good documentation isn't about writing an essay, it's about clarity. If an on-call doctor opens your notes at 2 o'clock in the morning, they should be able to scan it and instantly understand 3 things. First is what the problem is, then what has changed, and finally, what is the plan. It's also good practice to always document the why something has happened. For example, if you've held an ACE inhibitor, adjusted a gentamicin dose, or changed a fluid rate, briefly write down the blood trend or the fluid balance that made you do that. Remember that your notes are both a handover tool for the rest of the team and your colleagues, but also a legal record to help keep you and your patients safe. Now that we've covered the ward round prep, let's talk about what exactly you should be doing when you're reviewing a patient, either at the bedside and rounds or during an on-call. In those first 10 minutes, it's important to realise that you aren't trying to diagnose some weird and wonderful renal condition. You're simply trying to answer 3 basic questions. The first is that patient sick right now? You can run a quick A to E check, look at their news scores, and you need to establish what this patient's ceiling of care is. You then need to understand what their renal baseline is. A creatinine of 250 might be a catastrophic spike for one person, but completely normal for another. So it's really important that you look at the trend of the use in these rather than today's single number. And third, you need to ask yourself, what harm could happen to my patient in the next hour? You should scan specifically for life-threatening complications like hyperkalaemia, acidosis, fluid overload, severe hydration, obstruction, and unadjusted nephrotoxic drugs. If you get stuck with any of this in your initial assessment, you can always ask a senior for help. But answering these 3 core questions will help you control immediate risks, keep your patient safe, and give you a solid foundation to build upon the rest of your assessment. So after we've established whether our patient is stable or unstable, we then need to take a more detailed history. I'm sure by this point you guys know how to do medical clerking, so I'm not going to go through Socrates or a systems review. Instead, I want to highlight the renal specific details that can actually change your management. So first, we need to look at the patient's baseline renal function. We need to look at their historical bloods, look for any history of CKD or any previous admissions with AKI. Then we need to assess the patient's fluid status and urine output. Is my patient making urine? Is there a catheter or nephrostomy in situ? Is it actually draining? And then we need to ask about ongoing losses, things like vomiting and diarrhea or high stoma outputs. And then finally, we assess the patient for signs of overload, most commonly things like edema, peripheral swelling, or orthopnea. And the final thing we need to do is to do a thorough medication review. We need to screen specifically for nephrotoxic agents or renally cleared drugs, most commonly things like NSAIDs, ACE inhibitors, ARBs, diuretics, metformins, DOACs, or recent contrast use. Finally, if our patients are on dialysis or if they're transplant patients, it's really important we know their schedule, their access type, and their immunosuppression regimen, so we can ensure that adequate care is provided. These questions can help you understand why a patient's kidney function is potentially deteriorating and then further guide your immediate management plan. So moving on to the final part of your assessment, we have the physical examination. Your main goal in renal medicine is to answer one key question, and that is my patient dry, wet, or obstructed? First, we can look for signs of hypervolemia. Are there dry mucous membranes? Are there postural symptoms? Do they have core peripheries? Are there signs of hypervolemic shock? Then we can assess for potential overload. So we can assess carefully at the JVP. We can look for sacral and peripheral edema, and we can listen to lung crackles, particularly at the bases, and see if their oxygen requirement or weight is creeping up over the past few days. And finally, we need to rule out obstruction. We can palpate the abdomen for a distended bladder. We can check if there is an existing catheter or nephrostomy and ask ourselves if it's draining appropriately or bypassing. If despite all this, you are struggling to rule out obstruction, don't forget to consider things like stony disease or prostatic issues. Remember that patients don't always fit neatly into one singular box, however. Someone with sepsis and CKD can be intravascularly dry but peripherally edematous at the same time. So this is why it's really important that we combine our examination findings with our history, observations, and blood trends to build a sensible plan for this patient. Now that we've covered how to assess a renal patient, we're going to look at some of the actual conditions you'll encounter when you guys are F1s and F2s. The vast majority of your workload will centre around AKI, CKD complications, fluid overload, electrolyte disturbances, and investigating things like haematuria or proteinuria. You'll also care for dialysis of transplant patients and occasionally encounter more specialist conditions like nephrotic syndromes, glomerulonephritis, or vasculitis. The most important thing to keep in mind, as mentioned already, is that you were never expected to work out a definitive diagnosis on the spot. Your role is about getting the core priorities right, so spotting danger signs, ordering sensible first-line investigations, documenting clearly, and escalating appropriately. And this is exactly what we'll be focusing on for the rest of the session. Starting with the presentation, you'll see more than anything else, which is acute kidney injury. When you're dealing with an AKI, your very first step should be working out what category you're looking at. Is it pre-renal, intrinsic, or post-renal? So I'm sure you guys are aware that pre-renal is all about reduced kidney perfusion. So this is things like hypervolemia, sepsis, low BP, bleeding, or overdiuresis. Intrinsic means that there's damage to the kidney tissue itself, so commonly things like ATN, interstitial nephritis, or drug toxicity. And then finally, we have post-renal, which simply means that there's an obstruction anywhere along the urinary tract. An early indicator that a patient's kidneys are either struggling or they may be in the sort of early days of developing an AKI is a declining urine output. And this often drops long before the creatinine spikes, and so it's a really useful clinical hallmark that things are heading in the right direction from a renal point of view. Finally, when we assess patients for AKI, please don't forget to scan for red flag complications. This is things like hyperkalaemia, severe acidosis, pulmonary edema, uremia, sepsis, or acute obstruction, as these complications will dictate how quickly you need to intervene and escalate. Once you've recognised the fact that the patient has an AKI, you then need to figure out what to do first. Most hospitals will have their own local AKI bundle, so it's really important you'll follow your trust guidelines first. But in the absence of this, a helpful way to structure your management is using this A to E framework. So A is to address the medications first. You should stop or hold any nephrotoxic agents, dose adjust any renally cleared drugs, and if you're ever unsure, you can check the BNF, the renal drug database, or most simply, have a chat with your ward pharmacist. B is about managing blood pressure and maintaining renal perfusion. So this is things like treating sepsis or hypertension. C is all about circulation, which is where you assess fluid balance to combat hypervolemia or overload. And D is to dipstick the urine to either investigate for infection or proteinuria, which may indicate an intrinsic cause for AKI. And finally, we have E, which is to exclude obstruction. So now we're going to move away from AKI towards another classic bleep that you'll receive as an F1 or an F2. And this is, doctor, my patient hasn't passed any urine. The first question you need to ask yourself when you're taking this call is simply, how unwell is the patient? If there are any clinical concerns or if the observations are deranged, you need to head to the bedside and do an urgent A to E assessment. But in this case, we're going to assume they're stable. And the next thing you need to do is rule out a simple mechanical problem. So if they have a catheter or nephrostomy in situ, you can ask the nurse to check for kinks or give it a flush whilst you're walking over to the ward. Often this will resolve any small little blockages in the tubic. If the catheter is clear, or if they don't have anyone, or if they don't have one to begin with, your focus initially shifts to urinary retention. You can get a bladder scan, you can check if they're severely constipated and if this is pushing them into retention, and you can scan the drug chart for triggers like opiates and anticholinergics. Once you've ruled out either blocked piping or acute retention, that's the point where you need to take a step back from the patient and consider pre-renal AKI. You can assess their fluid status and decide if they actually need IV fluids because they're intravascularly depleted. So when you're doing a fluid assessment for a patient with AKI or low urine output, the goal is to figure out if they're really and truly dry. Remember that an AKI doesn't automatically mean that a patient needs IV fluids. If they aren't making any urine to begin with, giving more fluids won't fix the underlying cause, it's just going to cause overload. That's why every fluid assessment should systematically cover these three things. First, the history. This is where you look for volume losses like vomiting and diarrhea, or signs of overload like orthopnea. Second is the physical examination. This is when you can check the JPP, you can listen to the bases of the lung for crackles and look for any peripheral edema. And finally, you assess the data trends for this patient. You review their fluid balance and daily weights over the past 72 hours, look at their U's and E's, and if they've been producing any urine at all. Putting all this information together will help guide you whether to give your patients fluids, whether you should restrict their intake, or whether you need to start diuresing them. If, however, your assessment shows that your patient is unfortunately overloaded, your first move is to do simple things first. So you can consider stopping things like unnecessary IV fluids, reducing maintenance fluids, placing the patient on a low salt diet, and restricting their daily fluid intake. If, however, this is inadequate, or if the patient is acutely unwell, for example, they've developed significant pulmonary edema leading to a hypoxic event, you then need to decide how best to offload them. If they're still making urine, you can consider using a loop diuretic as your first line choice. If this doesn't work, you can either increase the dose or consider adding a second line agent like a thiazide-like diuretic. If they're completely anuric or not responding to high dose diuretics, you then need to escalate to a senior immediately for consideration of ultrafiltration via renal replacement therapy. Okay, so moving on to our next common bleep, which is hyperkalemia. I think hyperkalemia is often quite a stressful call because we all know how serious it can be. But before we rush to immediately prescribe treatment, it's really important we confirm the basics first. We need to verify the patient's identity and location and check importantly when that blood was drawn. We then need to assess the immediate danger. We need to go and see the patient. Is my patient symptomatic? Are they quite weak, or are they clinically unstable? The first thing we should be doing is getting an ECG to look for any hyperkalemic changes. If the patient is on dialysis, we also need to check whether that blood sample was either taken pre or post dialysis. And please remember that a high post dialysis result can suggest either an access issue or inadequate clearance, and they may need to go back to dialysis. Finally, we need to act and escalate. If it's severe hyperkalemia, if the patient's symptomatic, or if there are any ECG changes, we need to start emergency treatment immediately according to your local trust guidelines. This usually means that we give calcium gluconate to stabilize the myocardium and then insulin and dextrose to shift the potassium intracellularly. We should also consider stopping contributing medications like ACE inhibitors and ARBs, potassium-sparing diuretics like spironolactone, things like NSAIDs and potassium supplements, which can all drive up the potassium level. If despite this intervention, ECG changes persist or the potassium remains high, it's really important we involve our seniors as soon as possible for consideration of emergency dialysis to resolve refractory hyperkalemia. Finally, in terms of common bleeps, I wanted to cover haematuria. When we're called to see a patient with haematuria, the challenge here is working out whether you're dealing with a renal problem or a urological problem, because this will change the investigation of your order and who you need to involve. The first thing that's really important to establish, however, is whether this is an emergency. If the patient has heavy visible haematuria or is hemodynamically unstable or has gone into clot retention, you may need to urgently resuscitate the patient and trigger your local major hemorrhage protocol. However, if the patient is stable, you can then think about the pattern of disease. If there is visible hematuria with clots, urinary retention, or renal colic, this will point more towards a urological diagnosis and hint that we may need some surgical assistance. On the other hand, if there is blood and protein together on urine dipstick, this should make us think of an intrinsic renal cause for this presentation instead. So we've covered quite a few of the common renal problems and bleeps that you'll be dealing with on the ward or during your on-calls. But before we move on, I want to highlight a handful of situations where your immediate reaction should be, I need to act quickly or escalate as soon as possible. And these again can be broadly split into two core groups. The first group are the patients who are becoming physiologically unstable. So these are those with severe hyperkalemia, pulmonary edema, or severe acidosis or uremia. The second group are the problems that can't be solved with simple medical management alone. These are things like an infected obstructed kidney that needs urgent neurological decompression, as antibiotics alone won't treat the infection. It could be a transplant patient with rising creatinine and a falling urine output needing discussion with their transplant centre due to the risk of graft failure. Or it could be a dialysis line sepsis that needs rapid source control. If you're ever presented with any of these emergencies, it's really important we don't hesitate in involving our seniors and involve them as soon as possible. So now let's just take a moment to talk about prescribing. I think really prescribing can be quite scary, but it doesn't necessarily have to be complicated. And it can be helped by asking yourself 3 questions before you write any prescription. The first question is, what kidney function am I using? In stable CKD or patients without AKI, an EGFR is usually fine for dosing, but some drugs will still explicitly demand that you calculate a patient's creatinine clearance. If you're ever unsure, you can always double check in the BNF, the renal drug database, see if there are any local guidelines which cover that drug, or speak to your ward pharmacist. The second question is asking yourself, is this drug renally cleared or nephrotoxic? If so, you then need to decide how much you need to reduce a dose by, whether you should avoid the drug altogether, or whether you can still give the drug but adjust its timing around a patient's dialysis session to prevent toxicity or build up. And the final question is asking yourself, how am I going to monitor this drug in the patient? Drugs like vancomycin, digoxin, lithium, and tacrolimus all need therapeutic drug levels. And so you should document your monitoring plan in the notes and ask for help early if you're ever unsure. This is to prevent things like toxicity or subpart therapy, particularly in our immunosuppression regimens. Just to touch briefly upon dialysis for a few moments. I'm sure you'll all remember the AEIOU indications mnemonic from finals, but as an F1, you won't be prescribing dialysis, but you will be looking after these patients on the ward. So it's vital you understand the basics. Broadly speaking, renal replacement therapy does 2 things. It corrects biochemistry and it removes excess fluid. Haemodialysis is the most common form, where blood goes through an external filter via fistula, graft, or line to clear fluid and correct metabolic derangement. As a side note, it's really important that you remember to never cannulate, bleed, or put a BP cuff or tourniquet on a fistula arm unless specifically instructed by a renal team. Then moving on to peritoneal dialysis. This is where the patient uses their own peritoneum as the dialysis membrane. On the wards, the classic issue you'll encounter here are things like PD peritonitis, where the patient becomes septic with a cloudy peritoneal fluid. They may develop constipation or simply have a displaced catheter as well. And then finally, we have haemofiltration. This is more commonly used in ITU as it runs continuously rather than just restricted over a few hours. And it's far gentler on the patient. And so it's much better to use in situations where we have a critically unwell patient or those with hemodynamic instability. So now we're going to finish up by talking about holding the bleep, which is, I guess, one of the things that most incoming foundation doctors feel incredibly anxious about. The on-call setup that you're going to experience will vary depending upon the hospital that you're in. In some trusts, you'll cover all medical wards overnight with an SHO and a registrar. In others, you'll cover a cluster of 3 to 4 wards, including your base ward with cross-cover. Regardless of where you work, the core strategy for managing your bleep is identical. First, don't feel like you have to sprint to the ward every time your bleep goes off. Spend the first 30 seconds getting a clear SVR over the phone and asking who and where the patient is, why the person calling is worried, and what the patient's last observations were, what has changed, and what has been done so far. These quick questions will help you establish whether a patient needs immediate attention or if the job can wait. We then need to assess risk. You should ask yourself, if I delay this job by an hour, will my patient come to harm? A deteriorating patient, severe hyperkalaemia, or acute chest pain should immediately jump to the top of your priority list. Whereas things like TTOs, death verifications, or rewriting drug charts are important, but they can wait until sick patients are stable. And remember that once you've decided upon a job's priority, it isn't fixed. A routine query can quickly become an urgent task if new information comes to light, so it's okay to reprioritize as the night shift goes on. One thing I found really helpful during my on-calls was carrying a paper jobs list, which I'm sure you guys have all seen on your assistantships, and writing down every job as it comes in. You'll be interrupted constantly when you're on call, and it's surprisingly easy to forget something if you don't have a system in place. Also, try and remember that if you're ever tied up with a sick patient and it's taken quite a long time, it's always a good idea to let the other wards know that you'll come as soon as you can and that you may be a little bit delayed. Good communication goes a long way and helps to manage the expectations of our patients and the colleagues we work with during our on-calls. Finally, please remember that nobody expects you to know all the answers. Your job as an F1 and F2 is to assess the patient, start at the basics where appropriate, and ask for help when you need it. Your SHO and your registrar and the outreach team would always rather hear from you early on rather than after a patient has significantly deteriorated. One thing I found with my renal job is that there is a lot more to the specialty than the inpatient ward. And I would encourage you all to spend some time in the dialysis unit, attend a clinic, or sit in on an MDT, as it gives you a much better understanding of the patient journey and helps put a lot of what you see on the ward into context. Renal is also a great specialty for portfolio building. There are usually audits, quality improvement projects, and teaching opportunities already running. So if that's something you're interested in, it's worth mentioning it nice and early to a consultant or registrar early on in the placement. Even if you don't see yourself becoming a nephrologist, you'll gain a huge amount from this rotation. Looking after fluids, electrolytes, AKI, prescribing safely, are skills you'll use in almost every area of medicine. So it's a placement that has a value, dependent regardless of whatever career you decide to choose. Sorry. I think this is quite a useful slide. Foundation training, I know it did for me, goes by significantly faster than you expect it does. My biggest practical piece of advice for you guys is that you look at the self-assessment criteria for any specialties that you're interested in early on. You don't need to panic and try and tick every box in your first few months, but knowing what scores you points helps you spot opportunities as they pop up, rather than realising halfway through FY2 that you missed some simple wins. The good news is that most of the things that score quite well are things that we've already talked about today, things like teaching, QI, presentations, and these are all things that can naturally be done during any foundation job. Finally, don't feel under pressure to decide a career straight away. Please use your foundation training to explore different specialties, attend conferences, arrange taster weeks, build your portfolio gradually, and enjoy the opportunities that come your way. Starting foundation training is a huge transition, and it's completely normal to feel overwhelmed at times. If you take away one thing from today, remember that you are never alone and that you are part of a wide-reaching team, and you need to remember to use them. Try and stay organised and keep a detailed jobs list, and importantly, look after yourself, take your breaks, enjoy your leave, and give yourself a little bit of grace. Your job as an F1 isn't to know everything, it's just to be safe, ask questions, and keep learning. And if you guys do that, you'll become a confident foundation doctor much quicker than you think. Thank you very much for listening. I'd really appreciate if you can scan the QR code and complete the feedback form. Once this has been submitted, you'll automatically receive a summary page of the key learning points, which I hope you'll find useful when you start your placements in a few weeks' time. This is just a quick reminder that this session is intended as an educational overview. When you start working and you're looking after your patients in a few weeks' time, please do follow your local guidelines and seek senior support. If you have any questions about renal medicine, foundation training, or anything we've covered today, I'd be more than happy to answer them now alongside Zara, or feel free to get in touch afterwards via the email on screen. Congratulations again for graduating, and I wish you all the best of luck.